All right. We're going to go ahead and get started. I think what we want to do is we have a pretest, and we would like each of you to go through the pretest and answer the questions. And then, towards the end of Dr. Edwards' presentation, there'll be a post-test, and we'd like you to take the post-test out. There won't be a name. You don't have to put your name on it, so feel free to fill in the blanks. Everybody has pretest. Everybody got pretest. Okay, so what's the pretest? All right, I'd like to introduce our guest today, Dr. Morven S. Dr. Edwards is Professor of Pediatrics at Baylor College of Medicine and is on the Pediatric Infectious Disease faculty at Texas Children's Hospital. I've known Dr. Edwards for a number of years, and we're really honored and happy to have her here as our guest today. Dr. Edwards is really a national figure in pediatric infectious diseases. She is a real old-fashioned triple threat, excellent teacher, researcher, and clinician. Her career has really been punctuated by awards as a teacher. She actually won her first teaching award when she was a fellow. She completed her pediatric residency at Baylor and then a fellowship in Peds ID divided between Baylor College of Medicine and Channing Laboratory at Harvard. She came back to Baylor, where she has been on the faculty since that time and throughout her career. She's received teaching awards from the House staff as the Outstanding Faculty Teaching Attendant and the Pediatric Golden Award for Excellence in Teaching. So I think she's well established as an excellent teacher. She's held a number of national positions in Pediatric Infectious Disease Society, served as a liaison to the Infectious Disease Society of America, and has been involved in a number of areas related to continuing education, fellowship training, and the like. Her research has primarily been focused on bacterial infections in the newborn, and in particular, Group B strep infections. And over the years, she has really given us a great deal of information based on her research on the epidemiology of Group B strep, clinical manifestations, outcome of infection, short-term and long-term outcome of infection, and really has done a lot of work understanding the pathophysiology of the disease and ways to now prevent Group B strep infection, including considerations for a Group B strep vaccine, and is now working to help identify better the epidemiology of Group B strep infection in older adults. In addition, she's done a lot of clinical work where she's given us a lot of insights based on her publications in clinical infectious disease and a number of different pediatric infectious disease disorders. Published over nearly 160 original articles, over 60 chapters, and a large number of abstracts in pediatric infectious disease. And in fact, if you look at the major textbooks on bacterial infections in newborn and Group B strep, she's the lead author of most of the chapters in all of the major Peds ID textbooks. So today she's really here to talk to us about Chagas disease. And I'm going to let her tell you how she got interested and became a spokesperson for educating us on Chagas disease. But that's why she's here today, and we're really pleased to have her here. And so, Morven, I'm going to turn this over to you and let you educate us on Chagas.
Thank you. Yeah, I think that I've got a pointer here and an advancer.
Okay.
I'm set. Thank you. Good morning, you all. Thank you, Dr. Bocchini, for that lovely introduction. And it is my pleasure to get to be here in Shreveport. It's my first visit, and I totally, really like your city. And I've had a short tour of your hospital, and I like it a lot also. This is an unusual situation for me because we're going to speak about Chagas disease, which is an emerging infection that will impact us all. Let me begin by asking if it has impacted any of you here in the audience. Has anybody had cause to wonder if someone you're caring for has Chagas disease yet? Not yet. So I guess my main message is, by the end of the hour, I would kind of like you to feel like this is in your medical vocabulary, because there will be places where it will be important to question whether a child has this infection. I have no disclosures. This talk is a part of an educational grant in partnership. It's really cool. It's a cooperative agreement with the parasitic division of the CDC, and so I'm learning about it myself even as I get to speak with you all about it. So my slide set was developed in concert with the CDC, so they have gone through it to be sure what I say to you is accurate. I'd like us to at the end of the hour, I'd like you to feel that you can identify those who are at risk for Chagas disease in the U.S., that you would understand what to look for as a manifestation of infection, and that you would be able to describe how you would go about making the diagnosis. Which leads me to asking who you all are. How many of you are residents here in the program? Okay, that's the bulk. How many of you are faculty here in the department? And that's the other bulk. Are there other kinds of people here? Yes. What kind? Pardon?
I'm a resident for family medicine.
Oh, wonderful. Family medicine. We're glad you're there. You're perhaps even, it's more exciting to have you here than everybody else. Because it affects adults also. Okay. So has everybody had a chance to fill out that pretest? The pretest will give you a sense of how much you're learning, and the CDC, as part of the grant, appreciates that you're willing to take this test now and then to answer the same questions, the exact same questions, toward the end of the lecture. And this slide just kind of quotes a cardiologist whose name is Sheba Maimandi, who has a relatively large population of Hispanic patients, and who noticed that 20% of her adult Hispanic patients with heart failure had this new infection called Chagas disease that many U.S. physicians, our family physician, might not even suspect in someone with heart failure. And I have to smile at this slide because it says Chagas disease is joining an increasing list of infectious diseases such as dengue and chikungunya that are a concern in the United States, and that's in 2015. And so we would add Zika today, but it wasn't, we didn't have Zika yet. So Chagas is not an exotic disease anymore, but it's one that we have not yet considered. It is a parasitic disease, so that's the answer to the first question there, and it is caused by the parasite Trypanosoma cruzi. It's an infection of people that live primarily in Mexico and Central and South America. So what proportion of folks that you care for here in Shreveport have relatives how many are first or second generation Hispanic Latino folks here in your city? Less than 5%. That's going to be your target population. And so the parasite is not found outside the Americas, but all total there are 10,000 people who are walking around with disease, and most of them don't know they have it. And it is transmitted by this kind of cute little fellow called a kissing bug, or triatomine, and it's a cool way of transmission. It's not really very efficient because this is a blood-sucking insect, and he takes blood meals from you, and then the bug says, "Oh my goodness, that was just really the best blood meal I've had for a long time." And he has a gastrocolic kind of reflex. So after he bites, he poops. And the infection is not transmitted by the bite. It's transmitted if you rub the fecal material into the bite. So that's not very efficient. And most people who get this infection have not been bitten one time. They have had repeated chronic exposure to the bug. And this is the life cycle. It's one of those, if you'll just bear with me on these pictures, I think it'll all make great sense. So here's the bug, and he has just bitten you, and you have rubbed the fecal material into the bite, and here's what it looks like. This is the trypomastogote, and I would not want him in my blood. But that's what goes into us if we acquire the infection. And then after that, it transforms, it burrows into one of your cells and transforms into the amastogote stage, where it multiplies and kind of uses up the food materials in the cell. And here's what it looks like. So each one of these is going to burst forth after it uses up the resources in the cell and be infectious and looking for another cell to infect in your body. Right about now, people start scratching themselves. and this is, it seems to have a predilection for heart muscle and the muscle of the smooth intestine, smooth muscle of the intestinal wall. So here's amastogotes infecting heart muscle. And then what happens is, as it bursts out, it bursts out of a cell, transforms back into the trypomastogote, and repeats this cycle. And this cycle goes on chronically over years and years, and ends up letting a mom who has the infection transmit to her baby, or causing heart disease in an unsuspecting adult who doesn't know they were infected as a child. And at that point, if it has burst back out again, and along comes the triatamine and takes a blood meal from you, he ingests it, and it matures in his gut to be available to transmit again. So that's the story of how it is transmitted. Yes, you do have the kissing bug in Louisiana, and because there are 28 states, mainly in the southern U.S., that have the vector, and there are a number of mammals that can be infected by this parasite also. So if you live in a place that has both the vector and the reservoir, there's at risk for that part of the world to transmit infection. The little star here in Louisiana, actually up in North Louisiana, but no, it's just in Louisiana. The little star means that there has been at least one case, and there's a case report where infection was not only recognized in Louisiana, it was considered to have been acquired in Louisiana. But as yet, there's just a handful of those cases. So like me in Texas, our climate and our availability of the reservoir and the bug are sufficient to allow transmission, but it's just not a big problem at this point in time. This slide shows the areas endemic in red and the areas that have the infected, that have the vector and the mammalian species that can become infected. And I love that list of species because I've been speaking some about how much I like your terrain here, but I suspect that it has possums and that it has armadillos and that it has squirrels and skunks. And certainly this is a big problem in dogs. And if you go to how many of you all have dogs? If you go to your vet and say, do you know about Chagas disease? They're going to say yes, because it causes heart disease in dogs also. Okay, so with that introduction, has everybody sort of turned in their pre-test? Okay, so everybody's pre-tests are in, so we're going to launch into the population at risk. I thank you all so much for filling those out. So it is estimated that we have living in the United States at least 300,000 people who have Chagas disease, and most of them don't know it. They mostly come from Mexico, and for us in the U.S., it seems that in this location, it's going to be more from Central than South America, although some places like the Washington, D.C. area has a lot of big Bolivian population. And we've already talked about how we have the established cycle where it could continue to spread. And part of the reason that we now are talking about Chagas disease at this grand rounds, and it is at this moment settling in your medical vocabulary, is that a lot of people have come to the U.S. in the past decade or two from Central and South America. They've gone other places too, but there has been a lot of migration of that population into places in the U.S. And the big reason that we know that Chagas disease is a problem is that a decade ago, blood banks started screening for it. And that began in 2006, and they developed a second test in 2010. And so if you go to give blood, your blood will be screened to find out if you have it. And guidance was issued in 2010 that they just test you once, and they figure if you don't have it, then your chance of acquiring it in the U.S. is nominal right now, so you're not retested. But if you screen positive, then they'll not only reject your blood, but unfortunately, they would not let you give a kidney or heart either, because those can transmit infection also. And basically, all of our blood supply is now screened. And the CDC was able to set up an arrangement when all this started so that the places that people live when they screen positive are recorded. And we are just over 2,150 people now who have been screened positive in the past decade. And so this is just a subset of the people that have disease. And I just couldn't resist enlarging Louisiana. So to show that although you all are not exactly being overwhelmed with the number of people that have the infection, I counted 12 identified blood donors here. And I guess we get, unfortunately, I guess because it would make it so much more meaningful to you, Shreveport does not yet have a dot. But give it time, you all. Okay. So the pardon? What'd you all say? It'll get there. Okay. I'm glad we're in accord about the risk here. So the ways that someone can get it are direct vector-borne transmission. You can get it from the contaminated blood that is now not being passed along. If you live in South America, where there are some open air markets and a lot of the bugs that can transmit, you can acquire it from food or waterborne sources, but not in the U.S. And we would not be at risk for laboratory accidents. But one of the places it will touch pediatrics is in congenital infections. And moms with acute or more often chronic infection can transmit to their babies. So in thinking to one of the points to keep in mind is it doesn't matter if the mom has infection acquired last month before she came to the U.S. or whether she came to the U.S. 20 years ago and has chronic infection and doesn't know it. At any time after infection, a mother can transmit to her baby. So most of the time it's chronic infection, but it can happen at any time. And this is one of the manifestations in children. This is called a chagoma. It is a firm, painless swelling around the eye where if a child has either been bitten near the eye or actually in the conjunctiva and rubs that fecal material into the wound. This is acute Chagas infection in children in Central or South America. I have had consults. I've now started, as people are reading the internet, one of the kinds of calls that I get is my child has a swollen eye. It's not red, and the pediatrician refers the child to me because the mom is concerned that it might be Chagas disease, and what do we do? So usually if a bug bite has occurred, it doesn't have this firm, painless swelling that lasts for weeks. So that's one to know about. So let's look at the manifestations in pregnant women and infants. Here's after acute disease, which in most cases does not have a chagoma. If you are bitten enough times by the kissing bug that you've got those trypanosomes circulating in your blood, the first thing that happens is you get a flu-like illness. And many adults with a flu-like illness don't seek medical care. So it persists for several weeks. It could be a child who got infected, but then it enters a chronic phase, and you and the parasite will live together for the rest of your life. It comes into you, it does not go out of you without treatment. And so you enter what's called the indeterminate form of the infection, and a good 60 to 80% of people will go through their lives and not necessarily ever know they have it unless it's reactivated from immunosuppression. But that other 20 to 40% of people progress to having the determinate forms of the cardiomyopathy or gastrointestinal disease. Now these are unpleasant. The cardiomyopathy presents often in people who are in their, for example, 30s or 40s as cardiac arrhythmias that can be fatal, or as congestive heart failure that also can be fatal. So this is a big cause of heart disease in that population. When it enters the smooth muscles of the intestines, it produces a great deal of morbidity from constipation, but that's usually not a fatal condition. And one of the big problems here is when we get to treatment, the treatment does not reverse existing damage. So this is going to be another place where we as pediatricians and family doctors have an opportunity to make a diagnosis and treat infections early in affected infants so that it does not perpetuate itself and cause problems years later. So transmission occurs from mom to infant. So mom usually has chronic infection. She doesn't know it, and she's in the indeterminate phase. And she passes the infection transplacentally in the second or third trimester. It tends to like to go through parts of the placenta without a trophoblastic layer, so around the umbilicus. And transmission rates from a chronically infected person or an acutely infected person are not that high. The range, and this question will come up again, the range is 1 to 10%. So we should know that if we identify a mom with Chagas disease, 1 to 10% of her babies will acquire the infection. It may be higher in endemic countries, but even in people from an endemic country living in Spain, the transmission was as high as 14%. So just keep 1 to 10% in mind. And things that modulate transmission include parasitic load. If you have a lot of the parasite, you're more likely to transmit. And there are genotypes of this parasite that are not well studied, but it may be that some are better transmitted than others. As with other infections in mothers, HIV co-infection increases risk to the baby. And in terms of us as pediatricians, if we identify one patient in a family, all the family members should be tested because mothers can transmit from pregnancy after pregnancy. So all the children should be tested also. It seems that increasing maternal age is a risk factor, maybe because of the placenta becoming a little less efficient. And it's estimated that there are 40,000 women in the childbearing years in the U.S. with undiagnosed disease, most of them, and that there are 63 to 315. That's one of those work it out from the population things. So to round off, we should be identifying 50 to 500 infected babies in the U.S. every year, and so far we have identified a grand total of 2. So this is an infection that we're not thinking of as a medical community quite yet. Many babies appear normal at birth, but they're at risk for heart disease later on. However, 10 to 40% of those babies who are now infected present just like babies with other congenital infections. So how many of you all have had a rotation through the neo-ICU here in your hospital? Okay, a good number of you have. And have you seen any babies with congenital infections like syphilis? Yeah. This can present just like syphilis or congenital CMV. And this is the place, I'm sure I have missed this infection, because we do the tests for the usual suspects, and if all of them are negative and the person has a Latino background, that's where Chagas disease should be on our list. All of those findings, like hepatosplenomegaly, jaundice, anemia, that are signs of congenital infection, can be noted. And the only case report that is at this time published was a baby that was born in 2010 prematurely, who had lowish APGAR scores, and presented, interestingly, with ascites and pleural and pericardial effusions. That's not the first symptoms I would think of, but it sort of emerged in the history that his mom had Chagas disease, and when a blood smear was performed on the baby, he had trypanomastogotes circulating in his blood. And so this is the only report that's of the baby that's been diagnosed thus far in the United States. So I asked my colleagues, because I got to in hearing about the second case, what infection do you think of when you think of sort of ascites and pleural and pericardial effusions? Anything come to mind? It's kind of more like a hydropic baby with a parvovirus infection. And so the second baby apparently presented that way. So tuck that away also. It can present like that in these babies. So I asked my colleague at the CDC what she thought about both of these babies presenting with fetal hydrops. And she said, I think it's because we're only seeing the very tip of the iceberg at this point. So this is the only study, bless you, that I could find of a group of young children and their findings. And it may not be representative when we have more children to make the diagnosis in, but a presentation with sepsis and hepatosplenomegaly, sepsis, and then inflammation at end organ systems, myocarditis, hepatitis, meningoencephalitis are all possible presentations in infancy. Well, by now you may be thinking, wow, we don't have a very big population at risk. Only a subset of babies, 1 to 10%, are going to get infection from their moms. Only 10 to 40% are going to have symptoms. How am I, a simple pediatric house officer or faculty member, going to make this diagnosis? And you're right a little bit, because there's hurdles that we need to overcome. There's not any symptoms that are specific for the diagnosis, so the big problem is we don't consider it. And what I would put forth is, when you say, when should you consider this infection, I would say always. It should go right through our heads as a differential consideration, to be discarded if there's not a history that is consistent, or if the findings are not consistent. But we also need some studies to know what the prevalence to expect in the U.S. is, because we don't even know what the prevalence of infection in various states in the U.S. is. And that's where I came into Chagas disease. So about 6 years ago now, I got a consult as an infectious disease doctor from a pediatrician who sent me a patient who was an adolescent who had gone to give blood. And she lived in South Texas and had always lived in South Texas, and she screened positive for Chagas disease. So the pediatrician said, what should I do? And I said, I don't know. Go ahead and send her in. And that gave me time. And as a little aside here, there aren't very many things that you need to know right now in medicine. There are a few, but many you can take time to find out about. So that's what I did. I had this consult of an adolescent blood donor, and I called the CDC and said, I don't know what to do. And that was the beginning of my interaction. I learned that I should send confirmatory serologic testing, and that was confirmed. And then I learned about the treatment drugs and how to use them. And that led to Dr. Montgomery at the CDC saying, would you be interested in helping with a prevalence study? And I said, sure. That has not yet happened, but I called back up because I thought that I might have not heard. It was about 6 months later. And she said, well, we have a small pot of funds that has to be used before October. And if you would be interested, we could screen at your hospital. So my hospital is a hospital. We screened for a solid year at our hospital in Houston that has a large Latino population. It's called Bentab Hospital, and it has about 4,000 deliveries a year. And I have a really compulsive study nurse who wouldn't let us not get blood on people. So we were able to get 4,000 of 4,016 consecutive deliveries. We got the blood that was left over from the cord blood or leftover blood from mom's admission to the hospital. And this population was heavily Hispanic. And the screening test we did, screening tests are supposed to overread positive. So 0.7% of our population screened positive. And then by confirmatory testing, 0.25%, or 10 women who delivered babies were positive. When I set it up, I didn't think it was ethical to not contact these women, even though they hadn't specifically given permission because we'd used their leftover blood. So the CDC, the ethics committee, let me then identify them, and we asked them to come in. And here's what it worked out. The women who had Chagas disease were a little older than the rest of the group, and in this small population, they ended up being more often from El Salvador than from Mexico or Honduras. But that's the places we're seeing the infection in Houston. So when I was able to find 8 of the 10 moms, I was really disappointed I couldn't find all 10. But they had not heard of this infection that they had. They had chronic Chagas disease. They didn't know of anybody, they didn't themselves have heart or GI problems, and they had all lived in rural areas of Mexico or Central America. So if you have a Latino person and you're concerned for their baby, then you start to ask, did you live in a city or a rural area? And 6 of these women had lived in mud or adobe homes, and especially those with thatched roofs. And that's how they get the infection. That's how the chronic exposure occurs. The bugs live in the adobe walls or in the thatched roofs, and while you're happily sleeping away at night, they're there feeding on you and chronically feeding on you and transmitting the infection. And of the babies that I could follow, 7 had been born at term and 1 was premature, and we followed them out. It's like other infections where they get mom's antibodies, and you need to follow the babies long enough to know that the antibodies have gone away. So none of them got congenital infection, thankfully. So what do you do if you're suspecting it in your population here in Shreveport? And so nobody's ever ordered a test yet, but here's what you would do. The best test if you have acute infection is a PCR. But the only people that you and I are likely to see with an acute infection are a newborn baby. So we can send testing for a PCR to the CDC for babies if we suspect the infection. Do you all end up ordering more PCRs here than you used to? We make a lot of diagnoses by PCR now that we used to use serology for. But after that initial acute infection, for this disease, serology is going to usually be the best way to make the diagnosis. There are commercial screening tests, but if that is positive, it should be confirmed because the only validated tests are those through CDC, and they will do 2 different kinds of tests. They're called an ELISA and an immunoblot method. And if for a baby, if those are negative by 9 to 12 months, it excludes infection. We don't have any point of care tests that are approved yet. if you are giving, if you're ordering a screening test yourself, you should find out what test is done. In our community, we have two options, and one of the two commercial labs uses a test called the Wiener. That's easy to remember because it's wiener like a wiener. and it is a very good screening test. So if there's opportunity to use that one, it has less false positives. But if a screening test is positive, then again, you send blood to the CDC for further testing. So that's what you would do on an adolescent blood donor who screened positive, is go ahead and get the confirmatory testing. But there's no gold standard test for the disease, so that's another area that needs work. And if you yourself go to give blood, they will screen you with one of two tests. One is an ELISA, and one is a chemiluminescent immunoassay. And both of those are considered screening tests. In some places, they will do a second test before informing you that you might have this parasite in you, which is sort of scary. But in some places, they inform you after the first test. In either case, one should confirm that before thinking about providing treatment. And there's two antimicrobials for Chagas disease. That's great. But neither of them is licensed by the FDA. So this is an infection now embedded in your medical vocabulary, but it's got a number of hurdles to overcome. If you have to treat somebody, the drugs are released at no cost to your patient through the CDC. It involves a bit of paperwork, and they're both very good, but they have to be taken for a long time. Benznidazole is taken for 2 months, and nifurtimox for 3. Sometimes benznidazole is in short supply, and one uses nifurtimox. So I have, in my grand total Chagas experience, now treated 2 patients, one with each of the 2 drugs. And it's good, perhaps, to do that with Dr. Vancheri or Dr. Bocchini, and this is a good moment to say that when the beginnings of my coming and inviting myself to come speak, we're seeing Dr. Vancheri at a meeting, and he said, "We'll invite you to speak." I said, "Sold American," and I'm grateful to him, though he had to be out of town today. So, and the drugs are, the benznidazole has especially side effects that relate to dermatitis, and the nifurtimox has side effects that are unpleasant GI complications. So the good news here, and it gets down to, it's probably an easy question on that pretest is treatment in the first year of life curative? I'm not very good at asking questions, but the answer is it is. And that's why we need to identify these infected babies, because the treatment is essentially always curative if it can be given shortly after the infection was acquired. So if you and I can identify these infected babies and provide them the nifurtimox or the benznidazole, which, by the way, are very well tolerated in young infants by comparison with older folks, then we will have a 30% chance of having saved somebody a death from heart disease later on in life. The other places, if you go to your red book, it says very clearly that treatment is always recommended for children up to 18 years of age. We want to hopefully cure them. We don't have the data to know it cures it in adolescents, but they have been infected less long than older people. And also, it would potentially help their infants. And there are a good number of authorities that think we should be treating all women in the childbearing years if they are identified as having the infection, because it can be passed on to more than one child. So, if you all came into this room thinking, I don't know squat diddly about Chagas disease, and I'm not even quite sure why I'm going to this grand rounds, you're in good company. But I'm hoping that you're really getting excited that this is an infection that we're going to need to know more about. But you're in good company with our obstetric and gynecologic colleagues because there was a little survey published about them, and they need to know when to suspect this in pregnant women also. And they admitted to having very limited Chagas disease knowledge, and only 9% knew there was a risk of congenital infection. So it's an educational effort that needs to happen on, I like to think of it as both sides of the baby. But the most important thing is that we have to consider the diagnosis and request appropriate testing. In South America, it's perceived as a disease of poverty, so that stigma has to be removed also. I brought a row of printed materials there, and I hope that you will take them. The 4-page monograph really is a real good summary from CDC of the disease. And then 2 of the flyers are geared toward healthcare providers, and 2 are geared to women from endemic areas, regions, who might want to read about it to know if their infant is at risk. I also brought these so that you could go to the website yourself if you're interested. We are hoping to have a congenital infection handout and one that relates to concerns in children in the coming months. So those things are available. Your tax dollars pay for them, so avail yourself of them. There's also, I did not bring them, but the handouts are also downloadable in Spanish. So if you have Spanish-speaking patients, you can give them in their preferred tongue. And there are some pediatric-specific resources also. This is pretty cool. If you have a clinic and you wanted to make people aware of it, you can order these laminated posters to hang in your office that are in English on one side and Spanish on the other. So you can either have one and turn it over from one day to the next, or perhaps order 2. And Jessica, with great gratitude to you for all your help with my visit, this would be a great time to pass out the post-test. And again, as Jessica passes this out, I hope that if you started with none or limited knowledge, you are now bursting with feeling that you know about Chagas disease and have glued some of the central important facts into your mind. If any of you are on the faculty level need an hour and a quarter of CME credit, there's also a neat 3-part CME course for Chagas. You could glue in what you've heard this morning by going to the website and going through these 3 lessons that are available, and then claim your CME credit. I always like to do these online things because people don't know if I got the answers right or not. And then future directions. If any of you all are budding infectious diseases physicians and want an area that is just ripe for the picking, for learning some more about the infection, here's directions that we need to address. We really need to know the extent and distribution in the United States. We very much need a multi-center seroprevalence study. We need to know how much domestic vector-borne transmission is actually going on. And here's the next 2 are where my heart is. I believe that we should first identify the extent of the problem and then institute screening for at-risk pregnant women and or have Chagas on the neonatal screening test in appropriate places epidemiologically so that we can find out if these babies who get a congenital infection have it early in life. We really need some better performing diagnostic tests, and we need to have a screening test so we don't have to send things all the way to the CDC. We need a validated screening test that would allow the diagnosis to be made on site. And I don't know, have any of you all taken a medication for longer than 5 or 6 or 10 days? It's tough to take something for 2 months or 3 months. So we very much need new treatment modes for this infection. So now, as I say, I hope that you feel confident that you know the population at risk, when to think of the infection in terms of manifestations or even the lack of them. If it's a mom who is from Bolivia or Guatemala and she has a little baby, maybe that's not a bad place to ask a few more questions and perhaps screen. I had a physician, a GI doc, ask me, if I have an adolescent with chronic constipation, is that a place I should be screening? The question is, the answer is we don't have the data, but I probably would. And it's probably an okay place to say that I have the great privilege of having as a colleague one of Dr. Bocchini's daughters. And she sees our pediatric transplant patients and cares for them. And she has begun to include screening for Chagas disease in the adolescents of Latino background who present with chronic cardiomyopathies, which is a place we don't know prevalence, but we need to know more. And then the best practice procedures for diagnosis. Find out where you can send the screening, or the CDC is very much willing to answer your questions and to instruct you about sending a sample there. So I've mentioned Dr. Sue Montgomery. I now have the privilege of working with her and her colleagues in this cooperative agreement, but she will answer the phone at her desk. I don't know how she does it. If she is there in the office and you call the parasitic division, there you get the horse's mouth. So I will say again that she went through my slides and made a few little corrections. So I think what I've told you is accurate, and I appreciate you listening. Thanks so much.
Thank you very much, Morven. That was great. We do have a couple minutes for questions. I guess,
Yes.
Sarah?
If we identify a patient who had been infected and then we treated her, since we're checking based on serology, how would we check for a repeat infection?
That's great. Can everybody hear the questions okay? If we treated somebody, can we be sure they've not been reinfected? At this point, the risk is low when they have removed themselves from the endemic area. However, the first patient that I checked, I brought back 6 months later and repeated the serology. And sort of to my surprise, it was still positive, because I usually, it was just as high. And so even if you treat somebody, they can become seronegative over time, but it often takes years. So the answer to your question is there's not a good way to check, but it is unlikely that someone treated would become reinfected if they don't go back to the endemic area. That's a great question.
So I was going to ask, with the PCR, even with chronic parasitemia, is not effective in a chronic patient to look for evidence of continued replication?
The PCR is not sensitive to detection, is not as sensitive a tool for detection of chronic infection as for acute. In fact, it's usually negative in chronic infection because most of the parasite is intracellular. And so it's recommended that one skips that and goes right on to the serologic testing.
And then clinically, is there an eosinophilic response because of the tissue involvement, or is that not a response that occurs with this parasite?
The degree of eosinophilia is not dramatic. I can't further comment because it's not something. There's places in this infection where there's kind of fenestrations in the literature, because partly it's because some of it's in Spanish and I may not have found it, but I have not read reference to there being eosinophilia, and the patients that I have treated have not had it. So.
How are the titers reported when we get the serologies?
The way the titers are reported is really very, you don't have to be familiar with the assays to interpret the titers. They will give you an enzyme immunoassay number, and then they'll give you the reference range. And so you know that it's positive. And then they'll give you the TESA immunoblot is the second test done at CDC, and that's just a positive or negative. And both of those must be positive for them to consider the diagnosis. If both are positive, they may be coming back to you and saying, kind of, we'll release drug to you. So, yes, sir.
What about other non-specific markers? Are there any non-specific markers such as a SED rate that tends to be persistently elevated in chronic infection, or does it just disappear from the scene? So many other diseases.
That's a great question, because as an ID doctor, I tend to have a degree of great comfort if somebody does not have an elevated SED rate. But again, neither of the patients that I have identified has had an elevated SED rate. I think it's just the low-grade ongoing inflammatory process must not be sufficient to make a patient have, at least during the indeterminate phase, an elevated SED rate. Yes?
Can it be considered kind of like a bloodborne pathogen, like with somebody who injects drugs or something like that, be at risk for getting it?
Yes. If someone has the infection and they're injecting drugs, bloodborne transmission could occur that way. It's a bloodborne pathogen. Nobody has asked me that. That's very, very cool, and that's important, especially for adolescents, and I guess those who are prone to wanting to put things in themselves that don't belong there. Well, it's 2 minutes till 9, and most of the time, a lecturer who ends a minute or two early is better appreciated than one that goes over. So you're really nice. I look to the day when you find your first patient, and I want to hear about it. I thank you very much for coming. It's been a pleasure to be with you today. And thanks in advance. Please turn in your post-test and take these materials to read to put you to sleep tonight. Bye.